We do intend to start on time, but we have 9 minutes to go. So I will quickly go through the format of the Journal Club before we start off with the presentation. So first of all, this is the third in this series of Journal Club. We hold it on the first Saturday of every month, unless there are times and dates which are not feasible. So today we will be discussing this is the Colorectal Journal Club, and our schedule involves, this is we're here, we've done a breast and upper GI. The next Journal Club on the 4th of June will be hepatobiliary, and we will be covering the recently published PREOPANC trial looking at the neoadjuvant therapy in pancreatic cancer. In July, we will have an endocrine, which covers basically neuroendocrine, thyroid, adrenals. We haven't selected an article for that, but we're just discussing this with our faculty, and hopefully in the next couple of weeks, we will have that. In August, general surgical oncology, a paper pertaining to that will be discussed. And then we will go on to the same sequence of breast, upper GI, colorectal, HPV, endocrine, etc. Just to go through the rules, general rules, please, this is a request to all participants, apart from the faculty who may need to comment, but all participants are requested to mute their microphones. Please keep your comments and questions related to the article in question rather than the overall general principle. We will come to the general principle discussions after the appraisal of the article, and any questions or comments after the article has been discussed are welcome. Please raise your hand if you have to ask questions, or if you would want, you can type your comments related to the discussion. So basically, I think there are, if there are any questions or any comments before we start, we can actually have maybe 5 minutes to discuss if there are any questions that you would want to address. So while we have 5 minutes, maybe I can just to kind of make it a little more interesting. Is this in our general practice, do we see locally advanced rectal cancer more commonly than early rectal cancer, if you want to say that for lack of a better word?
Yeah, I certainly, I think that is the general thing until we have screening or till we even know who to screen, because the age of onset seems to be so much earlier and there's very often no family history. So I think at this point in time, I would wager that we don't even know who to screen in our population. So one thing that we can make better, I think, is general awareness amongst the primary point of contact. You know, everybody needs to be more aware of this, and perhaps we are not doing as good a job in making people aware of the sort of red flags of anal outlet bleeding. So I think till we have a better understanding of the epidemiology in our populations, the most we can do is education and awareness. Thank you.
Thank you, Dr. Sadaf. The other question that, because we have 3 minutes, maybe a quick comment, and I'd like Dr. Wahid, who's our faculty, or Dr. Irfan, welcome first of all. Is it necessary to gauge the distance from the anal verge of a rectal tumor with the help of a rigid sigmoidoscope? Because you see that mentioned in the guidelines, you see that mentioned in all the articles who define and then look at the management of rectal cancer. So is it necessary to use a rigid sigmoidoscope in the initial evaluation of rectal cancer to gauge the distance from anal verge?
Assalamu alaikum. Yes, I think it is important to gauge the initial distance. Obviously, the whole treatment plan depends how we are going to proceed with the treatment of rectal cancer. And obviously there is difference between the rectal and colon cancer and the neoadjuvant treatment for both of these. So I think it's really important to have a baseline measurement, what we are dealing with.
Is it, I mean, the whole question is, we see it being mentioned, but then again, in practice, we don't see it, at least I don't see it used as commonly. The other question is it more important for low rectal cancers or upper rectal cancers? Because for low rectal cancer, you could gauge the distance. And I think majority of the surgeons use this argument that you could probably gauge the distance with the help of a digital examination, and you will not require a rigid sigmoidoscope. More helpful in the upper rectal cancer. So would you say that we should always use a rigid sigmoidoscope in all rectal cancer populations?
Not really, as you have mentioned that with the low rectal cancer, it can be gauged easily with finger, and obviously the MR gives you a better measurements along with the finger measurements, physical examination, digital rectal examination. And for the upper rectal cancer, obviously when you are not able to feel it, then obviously you need to have some measurements, which can be either in the form of rigid sigmoidoscope or flexible one. But again, the discussion will obviously deviate from the path as well. Obviously with the low rectal cancer, as have the Sao Paulo groups and the neoadjuvant, and even for the, not even the locally advanced, like the early rectal cancers, they give neoadjuvant treatment to achieve complete clinical response. Obviously for them, the low rectal cancer is important because they would like to radiate and give neoadjuvant chemotherapy to get complete clinical response and follow them up and watch and wait. So obviously it is important. And if Dr. Wahid would like to add into it.
Yes, I'll take a quick comment from Dr. Sadaf, and perhaps because this is time already, we will start off with the presentation, then we'll continue this discussion later. Dr. Sadaf.
So I just wanted to add, look, when I was in training, everybody got a rigid sigmoidoscopy. But, you know, that point of the low rectal cancer is well within the reach of the finger, and that is as good as any guide of what the distance is. So that low is out. Then the middle, you run into a sort of gray zone. The thing is that, you know, with the decrease in availability of rigid sigmoidoscopes easily available in clinic and all that stuff, the MR has gotten much better. And I think that's what we're seeing here. It's not like it's not a good test. It's an excellent test. It's better than the flexible sigmoidoscope. It's easy to do, but then the availability, I don't think is great. And because MR to hona hi hota hai, and because MR is getting better, I think that's what we're seeing is a change, and the literature will follow. I don't want to keep going because you have to start now. Thanks.
Thank you, Dr. Sadaf. I think we'll probably continue this discussion later on. I think this is, we've reached the time. Let's ask Dr. Gibran Mohsin to start off his presentation. Dr. Gibran.
I am audible?
Yes, we can hear you.
Okay, I am Gibran Mohsin. Today we will discuss the RAPIDO trial, that is a randomized open-label phase 3 trial that compared the short-dose radiotherapy followed by chemotherapy before the surgery, but in comparison to the preoperative chemoradiation with optional adjuvant chemotherapy. So this RAPIDO stand for the rectal cancer and perioperative induction therapy followed by a dedicated operation. It was published in the Lancet Oncology in 7 December 2020. It has 184 citations. So these are a few applications that will be used during my presentation. So my outline of the presentation will be introduction followed by the method and further description of the further components of the method, then the result discussion, conclusion at the end, the critical appraisal. So the main aim of this study was that the systemic relapse remained the major problem in a locally advanced rectal cancer using the short-course radiotherapy followed by chemotherapy and delayed surgery, and this trial aimed to reduce the distant metastasis without compromising the local regional control. So at the moment, the standard of care for the locally advanced rectal cancer is the long-course chemoradiotherapy followed by the surgery as per the TNM principles, 6 to 8 weeks interval, followed by the adjuvant chemotherapy as per the institute protocol. It has been said that chemoradiotherapy is used to improve the local regional control, but in the Stockholm trial, it said that when you give a short dose, it leads to further downstaging if that is followed by the delayed surgery as compared to the immediate surgery within the few weeks. So adjuvant chemo was the main aim was to do to overcome the distant mets, but it has a decreased compliance. That's why it has an inconclusive evidence that it has any effect on the outcome. So there is a time period between the short-dose radiotherapy and the surgery, so that window can be used to provide the preoperative chemotherapy because it is associated with the improved compliance. So it will cover the both aspect of local renal failure and it risk of the distant metastasis. So it is said that that the alternate hypothesis of this trial was that it will improve the survival outcome. So the basis of this trial was they used the Dutch M1 trial in which they used the short-course chemoradiotherapy followed by the chemotherapy associated with the bevacizumab, and they said that it is for the stage 4 disease and it was associated with 84% compliance rate, and 1/3 of the patient they have a pathological complete response. So on the basis of this they used the same principle of the total neoadjuvant therapy for the locally advanced rectal cancer. So the objective of this trial was to reduce the disease-related treatment failure at the 3 year, and they have published in 3 different articles. The data on the compliance, austerity, and post-operative complication has been published in the separate article, and the functional outcome has yet to be published. And the main aim of this article was to publish the data about the primary endpoint after median follow-up of 4.6 years. So it was an open-label, multi-centered, randomized controlled phase 3 trial. It was conducted in 54 hospitals in 7 countries worldwide. So they included the tumor of which had biopsy-proven newly diagnosed primary locally advanced rectal adenocarcinoma with a distance extension of less than 16 centimeters from anal verge. And they used a TNM 5 that was very old now. The 8 has been involved, and they have used a T4A or T4B and 2 or extramucosal vascular invasion or involved mesorectal fascia, and the enlarged lateral lymph node was labeled as a metastatic tumor. So these are the further parameters of the patient which were used as an inclusion criteria in this trial. So if the tumor was involving the cranial part of the sacrum or the lumbosacral nerve roots, they were not part included in the trial, and metastatic and recurrent disease were also included. And the patient who have a complete linear response and they opt for watch and wait protocol, they were also not included. And even if they had that complete linear response, they were asked to undergo surgery as a part of the trial guidelines. So they have a ethical approval from all the center in which this trial was performed. So they did the randomization using the PRO-MIS data management system, and they used the blot design, and each blot size randomly chosen to contain 2 to 4 allocation in the random assignment of 1:1. So they stratified their data with respect to the institution, with respect to the T and N stage and the functional status of the patient. And since because of the nature of the intervention, the clinical staff and the patient, they were not masked, but the investigator, they were masked until the pre-specified number of events, that were 452, was reached. So all the patient underwent MRI, that was high resolution 3D to T2 weight, and the minimum parameter which should be mentioned in this MRI report has been shown in this picture. And to label the mesorectal or resto-mesorectal lymph node as a metastatic, they have used the size of the lymph node and other features that has been shown in the table. So what was the trial protocol? The experimental group have a short course radiotherapy in 5x5 derived pattern with a maximum of 8 days, in comparison to the 2 options of 50 or 50.4 derived in 28 or 28 5 fractions in the standard of care group. Experimental group was followed by the 18-week duration chemotherapy. After the 4 weeks after the last fraction of the radiotherapy, they have 2 regimes, 6 cycle of TAPOS or 9 cycle of FOLFOS4. In comparison to the standard of care group, they have a simultaneous were given the oral chemotherapy as a part of a chemo radiotherapy. And experimental group had the surgery after 2 to 4 weeks, in comparison to the surgery in the standard of care group at the interval of 6 to 10 weeks. In the standard of care group, they were followed by the adjuvant chemotherapy depending on the protocol of the center in which the trial was being done. And they included 8 cycle of TAPOS and or 12 cycle of FOLFOS4 in the adjuvant chemotherapy for the standard of care group. So the clinical target volume for the radiotherapy was the entire mesorectum that involved the primary tumor and the regional lymph node. Boost was optional, and the toxicity of the chemotherapy was, or the neoadjuvant therapy was assessed in using the CTCA version 4, and there was a reduction of 25% dose if there was seen any adverse effect. And the surgical complication were mentioned as using the classification of Cleveland window classification. The surgery was done TME principles, but for the proximal tumor, they have used the partial mesorectal HCM, and the open and laparoscopic approach was as per the surgeon's choice. And the all of the specimen were assessed using the residual tumor classification and the national guideline that include the minimum of whether the CRM was involved or not, and quality of the specimen was assessed at 2 levels in APR and at 1 level for anterior dissection. And complete tumor response was also been mentioned in the report. So this is the definition how they trial labeled, because we will see in the result what was the frequency of the serious adverse effect which were seen in 2 different groups. Any event that result in a death or is a life-threatening, that needed admission, that leads to disability, or that leads to a new event that affects the safety is labeled as a serious adverse effect. So as we all know that they have used the same minimal follow-up schedule as we normally do in our clinics. They do a clinical follow-up of using the CEA at multiple intervals, colonoscopy was mandatory at 1 year and at 60 months. And for the systemic metastasis, they have used CT or chest X-ray or ultrasound, and PET CT was optional. The functional outcome was also measured in this trial, but they have been will be published separately trial, and this is not the major topic of this article at the moment. So the primary endpoint was the disease-related treatment failure, but it is labeled as the first occurrence of a locoregional failure that was defined as a locally progressive disease that lead to an unresectable tumor or a local R2 resection or a local recurrence after R0 or R1 resection. Or anyone who has distant and metastasis or a new primary colorectal tumor or a treatment-related death was also labeled as a disease-related treatment failure. The secondary outcome was the how many patients they completed the neoadjuvant therapy, what was the percentage of R0 resection, pathological complete response was how much there, what is the effect on the overall survival or the local regional failure or a distant metastasis. So they have a changes in the protocol of which are 2 in number during their trial. The one was the primary endpoint. Initially, they set the primary endpoint of a disease-free survival, but before the 1 year end of inclusion, they changes to the disease-related treatment failure. The rationale was that because it is disease-free survival is mostly used in the adjuvant setting, and patients they were not disease-free at the time of randomization, and some will never become disease-free. The second change was that initially they had the hypothesis that their experimental group should have a disease in the event from 50% to 40%, but since at the median follow-up of 3 years, they said that they have a lower than the anticipated number of primary endpoint. That's why they changes to their hypothesis that the primary endpoint should change from 30% to 22.5%. So when they have used 80% power test, and the alpha significance or p-value of 0.05 was labeled as significant, and they did trial with the intention to treat, and overall survival, local regional failure, and distant metastasis were assessed, and the R0 resection and the pathological complete response in the patient who have a surgery were also assessed in this trial. So they have used SPSS 25 version, and they were appropriate to the type of data they have been used, and they have used our software for the survival analysis using the Kaplan-Meier method. So for the analysis of the local regional failure, they included are the patients who have or have not any evidence of distant metastasis. Same was for the analysis of a distant metastasis. And a patient who were alive and disease-free at the last follow-up, they were censored, and a median follow-up was calculated using the reverse Kaplan-Meier method. And a p-value was also calculated using the load rank test. So they have also done the sensitivity analysis to assess whether there is any time-related bias or not, whether the outcome has been affected by the stratification factors or not, or whether that outcome has been affected by the hospital policy of giving adjuvant chemotherapy or not. So the starting point for all of the analysis was at the date of the randomization, and the p-value of 0.05 was taken as significant. So this trial was registered by the Eurodrama CT and clinicaltrial.gov, and although they have 4 funding sources, but they said that the funders have no role in the study design, data collection or data analysis, interpretation or writing of this report. So this is a study profile that has shown that initially there included 920 patients who were randomly assigned, and 468 were assigned to the experimental group, and 452 were assigned to the standard of care group. Then amongst them, the 426 they had surgery with curative intent in the experimental group within 6 months of the end of neoadjuvant therapy, and in the standard of care group they have 400 patients who have undergone surgery with curative intent within the 6 months of the end of their treatment. And At the end, 423 patients, they have a resection within 6 months in comparison to 398 patients who have resection with 6 months. The difference was that the 3 patients, they were excluded because they were not underwent resection for the advanced disease, as compared to 2 patients who were excluded from standard of care 0 because they were of the advanced disease. So when we compare the baseline parameters, they were equally distributed between the 2 groups. The baseline characteristics was also with respect to the number of high-risk criteria, ethos status, distance from the anal verge, and the proportion of patients who were adjuvant chemotherapy were also almost equal in both groups. So from the baseline, they were equally distributed. So they included the patient over the time interval of 5 years, and the database was locked in 2020 with the median follow-up of 4.6 years, and the median time between randomization and surgery in the experimental group was around 25 weeks in comparison to 15 weeks in this standard of care group. So Kaplan-Meier curve for the cumulative probability of disease-related treatment failure shows that at 3 years there is the significant difference in the patient between 2 groups. We can see at the time of 3 years in the experimental group, 23.7% failure is only seen in comparison to 30% failure in the standard of care group with this significant p-value of 0.019. For the cumulative probability of distant metastasis, it is also clinically significant, statistically significant with a p-value of 0.0048. At the time of 3 years, it was 20% in the experimental in comparison to 26.8% in the standard of care. So the main reason of the improved outcome in terms of a disease-related treatment failure was the effect of a perioperative chemotherapy on the disease risk of distant metastasis. When we compare the 2 groups with respect to the local renal failure, there was clinically insignificant, statistically insignificant difference with the p-value of 0.12. So they have a sensitivity analysis for the time-based related biases, and for the stratification factors showed that there were not any association of any factor with respect to the original analysis that has been mentioned in the previous slide. As we can see that the main reason for a disease-related treatment failure was a distant metastasis, which was seen in 67% in the experimental group in comparison to the 81% in the standard of care group. So when we see the pathological outcome, it was seen that there is a statistically significant difference in the pathological complete response. It was almost double in the experimental group as compared to the standard of care group. And this is a point that has to be highlighted as well, because there is still significantly higher level of T3 and T4 diseases which are still seen in the patient of experimental group. These are the patients who might have a little or no response to the perioperative chemotherapy, and that is one of the factors. That's why they have suggested that the early response of a tumor to the chemotherapy should be assessed, so that a second-line chemotherapy or alternate therapy can be introduced on time. So the median time from the end of the radiotherapy to the start of chemotherapy was 14 days in the experimental group, and the use of the boost was almost equal, and the dose reduction was used in 44% of experimental group, but in comparison to 34% in the adjuvant chemotherapy group. And the regime in 99% was the course which are used in the experimental group. And premature stoppage of the chemotherapy was only done in 15% in comparison to 37% in the post-operative. That was because that shows there is an increased compliance of the pre-operative chemotherapy as compared to the post-operative chemotherapy. And the toxicity was more in the post-operative group as compared to pre-operative group. And the type of the surgical approach and the type of the resection has no effect on the outcomes. Adverse events of grade 3 and higher were seen in 48%. In comparison, the serious adverse event was seen in 38%. So, what about the overall survival? They at the 3-year follow-up, they showed there is a no effect on the overall survival between the two groups, but the limitation of the study was that it was having the median follow-up of 4.6 years. So when we have a further follow-up of this trial, there might be an effect on the overall survival, but at the moment we don't know. So amongst the adverse effect, the diarrhea was the most common adverse effect which was seen in the patient who have a experimental group, and also is one most common seen in the patient who have in the pre-operative therapy in the standard of care group. So overall, the mortality was also not different between two groups. It was 17% versus 18%, and the treatment-related death was 5% in both cases. So as a subgroup analysis of the primary endpoint as per the baseline statistics is consistently in the favor of the experimental group, and only 52% of the centers they offer adjuvant chemotherapy in the standard of care group, but this doesn't have any effect on the any of the 3 endpoints of this trial. So when we come to the discussion, we first we will have a overview of a disease-related treatment failure. It was significantly lower. It was mainly due to the low rate of a distant metastasis, which it is, they have mentioned 3 reasons. It was the better compliance of the shorter duration and the earlier start of chemotherapy with the more effective eradication of the micrometastasis. But since we have seen that there is no effect of the adjuvant chemotherapy on any of the 3 outcomes, it is suggests there is a low efficacy of adjuvant chemotherapy. Then if you look about the distant metastasis incidence at 3 years, it says that when we compare with the POLISH-2 trial that also compared the short dose radiotherapy plus chemotherapy versus the chemo radiotherapy, it also shows, they show that there is no difference. But in the RAPIDO trial, it was shown there is a difference. When we see that in the standard group, both they have a same percentages, it is due to the enrollment of a similar patient group, and the difference in the experimental group may be due to the duration of the pre-operative chemotherapy. A Chinese trial at the moment of the Stellar trial has also been done to show the effect of a number of chemotherapy cycles on the outcome of the. They have used the short dose chemo radiotherapy along with the 4 cycle of reports followed by the surgery with the 2 cycle of reports, and they will see whether the number of cycle of the chemotherapy has any effect on the outcome or not. So the third outcome was the local failure. It was similar to the previously published data, and there are 2 points which are in the favor that the more the duration between the radiotherapy and the surgery, there is an increased chances of downstaging with the increased chances of pathological complete response with the increased chances of the organ preservation. But there is a disadvantage that few of the patient might progress if they have a little or no response, as we see previously that they have a higher T4 on post surgery specimen as compared to the standard of care group. So pathological complete response was doubled in the RAPIDO trial that has a potential opportunity for organ preservation, and in the Stockholm 3 trial they showed that the delayed surgery is associated with the increased chances of pathological complete response, while the other trial of intermediate risk rectal cancer has also shown that the pre-operative chemotherapy is associated with the increased chances of pathological complete response. So there are 2 main factors which affects the incidence of pathological complete response. One is the interval between the radiotherapy and surgery. Second is the number of cycles of chemotherapy. So overall survival has no effect at the median follow-up 4.6, but there is need of longer follow-up of up to 10 years before any final comment and we made on this. Then there is another debate about what is the optimal time of chemotherapy in total neoadjuvant therapy. So if the rationale of starting from the radiotherapy is that we will should have a control of a local progression, and the rationale of using chemotherapy first is that we should have an early control of a metastasis. There is a trial Prodigy 23 trial that shows that is comparing the long-course chemoradiotherapy with or without the chemotherapy before that chemoradiotherapy, and they showed there is significantly increased 3-year disease-free survival, metastatic-free survival, and a pathology complete response in a patient who have a chemotherapy before the start of chemoradiotherapy. So the optimal is still under debate, and it is at the moment the chemotherapy is given after the short course chemotherapy because it is associated with a fewer adverse event, better compliance to the chemoradiotherapy with a higher risk, chances of pathological complete response, and but at the moment long-term oncological results are awaited. So serious adverse effects were seen more in the experimental group, but they have no effect on the surgery. So what is the merit and demerits of short course versus long course chemoradiotherapy? It is associated merit is short duration and minimum delay in the start of the pre-operative chemotherapy, but there is no RCT on the downstaging effect with the similar delayed surgery. But at the moment, it is said that at the moment we don't know whether it is more effective or not, and the long-term morbidity is also not comparable because also there are two RCT, but the long course is not been well studied, and we have to be very careful when we are using the interpretation from these trials because they were trial which uses the old method of delivery of radiotherapy, and the target volume has also changed now. So the limitation of study was the alteration of a primary endpoint. There was absence of central review of the baseline MRI and the primary endpoint and the short duration, and we don't have any final comment on the benefit in terms of overall survival. They have also mentioned that this experimental group has a decreased hospital stay. So with the 12 days versus the 25 to 28 days. So in context of COVID-19, it is also been preferred during the COVID pandemic. So in conclusion, the high risk broadly advanced rectal cancer, the standard of the care, they have suggested a new standard of care which is supported by the high compliance and the tolerance that short course chemoradiotherapy should be followed by the 18 weeks of chemotherapy followed by surgery in comparison to the radiotherapy with or without adjuvant chemotherapy because it is associated with the decreased probability of the disease-related treatment failure and mainly by reducing the probability of distant match. They have suggested that their experimental protocol has which should and we also use because it of the higher chances of the pathological complete response and there is a potential for organ preservation. But this suggests that there further research is needed for the early assessment of tumor response or systemic therapy so that the alternate therapy can be introduced as soon as possible to increase the efficacy with further decrease in the distant metastasis. So after the conclusion, little appraisal component will be discussed. So is the first question that arises that is the study research question relevant? Yes, that was relevant to our field. Does the study add anything new? Yes, it has added to our new because it has further provide evidence in the favor of a total neoadjuvant therapy. So what type of study research does the study pose? It shows that it mainly see the effect of the intervention on the outcome. So yes, the study design was in line with the research theory, and the method of randomization was also well selected, and they have used methods to avoid the systemic bias, and all the not all of the participants they were present till the end, and the original protocol was not followed. They have changed their two components of their initial protocol. Yes, they have also tested the alternate hypothesis as well, and they were patient were blinded, no, not blinded. The investigator was blinded till the predefined number of cases and even were reached, and the study baseline parameters, they were also equally distributed between two zeros. And apart from the experimental intervention, they have used equal number of follow-up, and they have the same for surveillance. Yes, the power was 80%. The p-value was also 0.05. That was all right, and they have also removed the bias using the statistician, and the confidence interval of 95% was used. That was also all right, and the benefit was more than the harm and the cost, and it justified. The data is in line with the conclusion, and also they have mentioned that there is no conflict of interest with the funding agencies. So will these results then be applied in our local? At the moment, we are still using the traditional regime, but yes, this has been an option for us to have a total neoadjuvant therapy for the patient who have a locally advanced rectal cancer. Thank you very much.
Thank you very much, Dr. Gibran. That was a very nice overview. I would request you to please stop sharing your screen so we can start our discussion off with the discussion with the faculty. So our faculty are here. For those of us who are joined in the beginning, I will introduce our faculty. Dr. Khan is a colorectal surgeon at the Aga Khan University. Dr. Sari Shibrar is a radiation oncologist at the Aga Khan University. Khan Nasir, a surgical oncologist in Tower. Wahid Anwar, I think, is not with us. But he is a consultant surgeon, surgical oncologist at the Shah Khanam Hospital, Lahore. So, any starting comments on the study? Dr. Irfan?
Yes, can I start?
Yes, please.
Thank you. So thank you so much,
Dr. With radiation first, so we'll start off with radiation, yes.
Okay, so thank you so much, Dr. Gibran, for this wonderful overview of this study. I have many points to make. First of all, there are obviously positive and negative points of the studies. The RAPIDO study came when the COVID-19 pandemic was at its peak, right? And they utilized the short course regime in this trial. So the short course regime is not, the US is not actually the proponent of short course regime. They favored long course regime because of the fear of lose of, local control. But when the COVID-19 came and because of the pandemic, the US people also, embraced this study. And they made the protocol, and MSKCC made a protocol, and they started doing short course radiation, and it was accepted. I think globally people started doing short course radiation. I think जो study का intent था वो ये था कि they want to improve the distant control and not to compromise over the local regional control. If you see the distribution of the patients in both the groups, you see in the experimental arm, what they did, they do the short course radiation, then they had 18 weeks of chemotherapy, and then the patient had the surgery. So 84% of the patients in this study received chemotherapy, while in the standard of the care group, only 58% of the patients received chemotherapy, because the chemotherapy which was received in the adjuvant setting after the surgery, it was an optional thing. It depends upon the patients whether to receive or not. I think this is the biggest bias of this study, and अगर ये optional नहीं होता तो maybe results different होते. This is what I think. Because हमें सबसे ज़्यादा जो इसमें important चीज़ नजर आई है वो है distant control. Less liver metastases were seen in this study.
Fair enough. That's a very valid point. But Dr. Sairesh, would you agree that the intent of the study was to compare an experimental protocol of short course radiation with a delay in surgery and incorporating systemic therapy during that delay? And this experimental protocol was compared with the then current standard of care, which would be long course chemoradiation followed by surgery and use of adjuvant therapy selectively in some patients.
Yes.
So with that respect, I would tend to contend that in that aspect, the standard of care was followed, that not everybody received adjuvant therapy, because that's what my understanding is, the standard of care before RAPIDO, if you would want to say.
Yes, you're right. Not everybody received chemotherapy, but in this trial particularly, they keep the adjuvant chemotherapy as an option, whether to receive it or not. Right. So I think this is a bias of this study. And other than that, I want to make one more comment that recently an abstract has been published in European Journal of Surgical Oncology in February 2022, and they have reported the 5-year update results. I mean, 5-year results. Yes. So in that, in those results, they have the conclusion that in the initial study, which was published in 2020 December, there was no difference in loco-regional failure in both the groups. The loco-regional control was equal in both the groups, in the standard and the experimental arm. But in that abstract, which has been published recently, they reported that there are more local failure in the experimental arm, and I think we have to be more cautious using this approach short course. Before this study, I was proponent, and I was saying at every forum that we should use short course regime because it favors us, because we have less setups of radiation oncology, and short course suits our setups. But with this kind of results, I think we have to be more vigilant.
Fair enough. What would the surgeon's point of view been? Dr. Sadaf, Dr. Irfan?
Yeah, Dr. Sadaf, if you would like to go first. Your mic is mute.
Thank you for Dr. Gibran for the fantastic overview. It was a lot of information that you really condensed well. Look, a few things that I would say is that these are things that we have suspected, and I think this study, because it's just a 3-year follow-up, we really can't say for certain, but it seems to me things are going in the right direction. And some of the things that we suspected was that the fact that we were not able to complete chemotherapy postoperatively was having a negative effect on our patients, number one, because not like almost half patients, without going into the definite numbers, a lot of patients don't make it through to chemo or are unable to tolerate it because they have just gone through big operations. There is also a delay in chemo, and every surgeon knows the pain of there being a wound infection and you stressing out, chemo delay ho jayegi. So this preoperatively, and we've suspected this for a while, that, if we could do it when they're in good health and, the best health that they can be, they will do much better with it. So that's one thing that this study seems to support. The other thing, this is something that has been the debate for a long time, is the duration between the completion of radiation and surgery. When the standard care therapy first started, 15, 20 years ago, surgeons were even nervous at the 8-week mark, right? 6 weeks, we were scheduling patients and, sweating bullets if it went into the 7th week, because there was this fear that at 6 weeks you have the ideal edema, and then at 7, 8 weeks you start getting fibrosis, and that it becomes impossible, and you lose blood, and it becomes a very complicated operation. However, time has proven that not to be true. But what time has shown is that radiation really is a gift that keeps on giving, as borne out by radiation enteritis and radiation cystitis. The radiation effects, and I'm not saying that we keep it forever, but what I'm saying is that radiation continues to work for a certain period of time because of the vasculitis it causes. And so what this does is that the side thing is that there is an increase in time between the completion of radiation and surgery, and that can be held responsible for the higher rate of pathologic complete response, which I would put forward is something that ultimately should be the goal. I mean, we should be able to do chemo and radiation to the point where surgeons become obsolete, because it is such a disfiguring and such a difficult operation. So that's one point. The next is the early attention to micrometastases. And again, the same point of when you actually get chemo, ek to ho ke chemo complete ho, dusra ho ki chemo aapko milega. And the preoperative chemotherapy, and I'm not saying with short course or long course, but preoperative chemotherapy certainly intuitively seems to be a good option, just even intuitively, and it seems to be borne out by multiple studies at this point in time. And then the last thing, what Dr. Serish talked about was to be aware that everybody shouldn't get on the bandwagon of short course. I agree with that to the point that not every center is able to do IMRT and to do it effectively. Just because you have the machine doesn't mean that you have the expertise, and vice versa. So just any short course isn't the short course that we're looking at. We're looking at IMRT that goes directly to the tumor, that has the 1 centimeter margin, the whole thing. I'm not a radiation oncologist, but of my limited understanding of IMRT, it's much more than the full zapping of high dose radiation to the entire pelvis, which in itself can have very significant side effects. And that is what the early studies of short course, that's why it wasn't really in favor. And that's why the US, there was an initial spate of studies that showed more side effects. And that was because radiation hadn't developed to the point that it is here. So just as, we can say that, yes, not every short course therapy is the same, I would caution to say that those that have sort of the IMRT machines, who have the expertise, should certainly go ahead and use it. But those who do not have it need to weigh patient safety and efficacy, according to their own context. And in our setups, context is very important. You can have different contexts like 1 mile apart. And I think we have to, the interest of the patient is prime, and we all have to make decisions according to what our context is. Thank you very much.
Thank you, Dr. Sadaf. Dr. Irfan, your comments, please.
Yeah, first of all, it was a very well presentation from Dr. Gibran, well summarized and well presented. Yeah, I would agree with Dr. Serish in a sense that obviously the adjuvant chemotherapy that was optional left to the centers, and some of the European countries, they don't actually follow the adjuvant protocol after the surgery. And if it's left, obviously there, and obviously in this trial, we are discussing locally advanced tumors who, in most of the patient who would definitely need adjuvant treatment in the standard of care group. Second, if we look at the short course radiotherapy, so even in this trial, they have mentioned that the local control was not achieved in 17% of the patient in the experimental arm as compared to 10% in the standard of treatment care group. So obviously there is increase in number of the local failure in the experimental arm. And as Dr. Sarish mentioned, that they have mentioned their 5-year survival, in which again they have re-verified their results with increase in the local failure in the experimental arm. So we need to be a bit careful with the implementation of short course radiotherapy. And again, obviously we as a developing country, we don't have all the expertise. And as Dr. Sadaf mentioned as well, that not everyone is trained if they have the equipment, and if they have, and those who are trained, they won't be having the equipment then. So there is a mismatch in this as well. Regarding the increase in the whole complete clinical response. So where I was trained, we used to have locally advanced, obviously rectal cancer. They would give neoadjuvant treatment to the locally advanced rectal cancers. And then obviously they would scan the patient early in 4 to 6 weeks. And if there is a good response, they will give consolidation chemo. And they were able to achieve 60% complete clinical response in 10 to 12 weeks. And those who had good clinical response, they would keep them in watch and wait and give further consolidation chemo. So again, this study obviously is a very good study in a sense that it is a proponent, or it is suggesting, and obviously we are going towards total neoadjuvant therapy as compared to standard of care when it's optional as well. And apart from that, not every patient gets adjuvant chemotherapy, and not all of them are able to receive it. So yes, I think it's a good study in a sense that we are moving towards neoadjuvant treatment, but then again, we have to be a bit cautious with the short course.
So one of the differences, I mean, we do identify there are differences in the protocols of management in the two groups. Dr. Sarish, would you consider it a direct comparison between a short course versus a standard 28 fraction long course of? Would you say that the differences in outcomes in terms of the local regional control would be a difference in the management based on the radiation strategy?
Are you asking about the radiation planning or the results, the local control? I can answer both the questions. All right. So regarding the radiation planning, I want to make a few points here, which are very important. That if somebody is is going to opt for the short course radiation therapy, one has to have an MRI before radiation planning. Right. So before radiation planning, we have to have an MRI, at least T2 weighted images. So we can fuse those MRI with the planning CT scans, and we can accurately contour our target volume. All right. And then the second point is that we have to have daily imaging before treatment. So the ideal protocol is when you are doing the short course radiation, the physician should be on the setup while the patient is on the setup and is being prepared for the treatment. When we actually set up the patient, we should take the images, and we should verify the treatment images and the plan images, that whether we are we are targeting the same area which we are intending to, or we have planned. So that's the mandatory protocol if you're following the short course regime, right? So if we lose, if we lose 20% of the local control if you miss any area in 1 day of radiation. So you would lose 20% of the local control, because we are going to deliver only 5 fractions. Whereas in the long course radiation therapy, we need to have an MRI. Obviously, we need to have an MRI before radiation planning, and we do plan. We do our radiation plans with the help of those MRI, but it's not mandatory while you are treating the patient for 28 times. It's not mandatory for the physician to be there before the treatment. We can do the offline imaging review, like what our practice is, that our technicians deliver the treatment, and after the treatment we check their images, because on daily basis we are not giving a very high dose of radiation. We are just giving 1.8 gray of radiation, while when we are doing the short course radiation, we are giving the 5 gray per day. So if अगर हम कोई चीज मिस भी करते हैं तो हम बहुत थोड़ा सा रेडिएशन का कोई हम थोड़ा सा मिस कर रहे होते हैं. But if you're missing anything in short course regime, so actually we are missing the 20% of we are losing the 20% of the local control. Right. Now, regarding the loco-regional control, there is always debate about the the local regional control with the short course regime versus with the long course regime. So in the RAPIDO study, this is the only study where the short course regime was used, and there is a gap of 24 weeks, and then the surgery has been done. So we cannot predict the relative efficacy of this short course regime with this gap. So I think we need to see the long-term results.
Sorry, Dr. Arish, I did not quite understand. So is there a difference, as in you said that you would require imaging on a daily basis? Yes. Is that day-to-day change in the planning occurs because of change in the size of the tumor?
No.
Or is that because of change in the positioning of the patient?
There can be two things. The patient setup. The patient's setup can be vary on daily basis. I mean, we have to look after the millimeters, the movement of millimeters. Right. So one is the setup, and the second is the internal organ motions. The motion of intestine, the the urinary bladder filling, the differences of the urinary bladder filling. We have to see all these things on daily basis. Can you hear me, Dr. Azhar?
Yes. So now the one question to Dr. Sadaf, Dr. Irfan. We did talk about delay in surgery. Do you think it would be okay to assume that now we have become comfortable with operating up to 12 weeks following radiation therapy? Does delaying surgery up to that time make any difference to the operation or the tissues in any way, in your experience?
So, yeah, not in my experience, because as I previously mentioned as well, where I was working, we used to have watch and wait strategy as well. And those patients who develop regrowth, so more than 90% of the patients have got the same primary intent surgery which they would have received if they were not in the watch and wait. And obviously the operations were more or less similar without excess fibrosis or edema in the tissue planes. So I don't think so that now, in my understanding, it doesn't make any difference if we operate the patient at 8 weeks or 12 weeks or more than 12 weeks. The planes are more or less similar. And obviously, as the expertise is increasing, I think things seems to be moving in the right direction. What are your thoughts, Dr. Sadaf?
I agree. I think early on, like 15, 20 years ago, there were issues. And I've been in cases where at 10 weeks, for one reason or the other, be severe scarring. You couldn't tell where the mesorectum ended and where the fascia started. But I think radiation has come a long way. It's changed in leaps and bounds. The machines have much more finesse than they had before. And so at this point in time, I really see no difference at all. And I think it has taken a while for surgeons to become more comfortable with giving it more delays. But I think what is important is that there should be sort of a mid-treatment or an early scan to make sure that disease isn't progressing, because a lot of you have also seen disease that is very, very refractory to treatment. And that would be a mistake, certainly, to sit on something that is growing on treatment. In fact, if it grows on treatment, that sort of, to me, is a sure shot sign that this is a more sinister pathology, and that it would do everybody well to sort of bump up the chemotherapy that is being given, because even surgery isn't going to treat that disease. That disease is just a different beast altogether. So yeah, those are my thoughts. Thank you.
Very much. I would request, we have other senior faculty members, Professor Khalid Durrani, Professor Harun Javed, Professor Shatima. What are your thoughts and comments on the study itself? In the meantime, if we have any comments or questions related to the article, the participants can raise their hand, post them in the chat box. Thank you.
Dr. Raza, may I?
Yes, sir. Thank you so much for joining, sir. Please.
Thank you. My thoughts about RAPIDO trial. I would like to say that this is pertaining to the concept of total neoadjuvant treatment, and the theoretical advantage of total neoadjuvant treatment. Let me recapitulate what is the objective of total neoadjuvant treatment. Ideally, one would expect a very high compliance rate, and therefore one would also expect improvement in micrometastasis and distant failure. The other possible advantage could be you test tumor biology by giving chemotherapy in the pre-operative or neoadjuvant setting, and also the response of response of the disease to the chemotherapy. Then it is also possible that you may achieve a better R0 resection with neoadjuvant chemotherapy, but more specifically because of the chemoradiation, and better chance of sphincter preservation. Now, the question as to how far RAPIDO has answered these questions is, I think there are two main advantages or two main subtle findings which are shown by RAPIDO trial, and these are the disease-related treatment failure is improved by 7% in the experimental, which is the TNT arm. And the second advantage of the TNT treatment was doubling of the pathological complete response. So these 2 points are obviously in favor of this particular trial. But still there are certain questionable issues that needs to be addressed. And I'll say some of them, which is that in RAPIDO trial, if you note that 30% of these patients had tumors of the upper half, upper 1/3 of the rectum, which probably would not benefit from short course chemoradiotherapy. Because when we are considering locally advanced rectal cancer, we are mainly concerned about the middle third and the distal third of the rectum, in which we would like to have an R0 resection, and of course we would like to have a better locoregional control. The other point is that the disease-free survival, overall survival, stoma rate, abdominoperineal resection rates were not different in the two arms, between the standard arm as well as the experimental arm. Then if you note the toxicity, particularly grade 4 toxicity, were double in the experimental arm as compared to the standard arm. Whereas overall, the overall toxicity was not different between the two groups, but the grade 4 toxicity is almost twice that of the standard arm. Then one other minor point is conversion rate. Those patients who underwent laparoscopic resections, the conversion rates were higher in the experimental arm, that is the TNT arm, as compared to the standard arm. And the researchers are of the opinion that probably the higher conversion rate is due to the technical difficulty of laparoscopic resection, as well as due to a higher blood loss in those patients who underwent the totally neoadjuvant treatment. Then local recurrence rate, although there was very slight difference, but the local recurrence rate was slightly higher in the experimental arm. I don't know why is the reason, whereas in the experimental arm, the time lapse between the end of the radiotherapy and the TME is much longer, and you expect a better local control in the experimental arm as compared to the standard arm. So these are some of the points which one can consider as far as RAPIDO is concerned. I was wondering if you could, we could also discuss the French trial, which is PRODIGE 23. That also pertains to the total neoadjuvant treatment. But in that trial, they have tried the long course radiotherapy, which is, I think, as I understand from the previous discussion, which is far more common both in the United States particularly and also in the Europe. So the difference between the PRODIGE 23 and RAPIDO trial is that in RAPIDO trial, chemotherapy is given as a consolidation regime, whereas in the PRODIGE arm, the chemotherapy is given as an induction treatment. And both trials have shown definite advantage in the, as far as the treatment failure is concerned. And mainly this difference is due to decreased distant failure in the experimental arm as compared to the standard arm. Now, some of the, what can we conclude as a result of this RAPIDO trial? I have noted down one or two points. One is that, does this treatment fit all of our patients with locally advanced rectal cancer? I think the question has not yet been answered. And perhaps there are a select group of patients in which we can try this regime according to the RAPIDO trial. The other question would be whether chemotherapy should be given as in the induction setting or in the consolidation setting. This question has also not been answered in any of the two trials, although both trials have shown advantage as far as disease distant failure is concerned, but local control has not been affected by either by giving chemotherapy in the induction setting or in the consolidation setting. The other point perhaps would be that TNT has not been able to change the extent of surgery. The number of patients who had APR is more or less the same in both the arms, standard as well as the treatment arm. I've already mentioned about grade 4 toxicity, which is also double. Then none of the TNT arms has shown any effect on locoregional disease. This means that chemotherapy probably has minimal effect on the local disease. Then the last point perhaps would be that both trials have shown no significant benefit as far as the quality of life score is concerned or the global health status is concerned. So these are some of my views. But finally, I would like to mention that we have not discussed the surgical aspect in the management of locally advanced rectal cancer, and that pertains to the total mesorectal excision. I think we as surgeons should emphasize more on training of our residents as well as our junior surgeons in the exact performance of total mesorectal ASEAN and what total mesorectal ASEAN is meant by, and what percentage of our patients in which we have performed this low anterior resection or low anterior, ultra low anterior resection, what percentage of these patients actually had total mesorectal ASEAN? And perhaps you would also agree, and most of my surgical colleagues would agree, that at least 90% of our specimens should be complete as far as total mesorectal ASEAN is concerned. Thank you.
Thank you very much, sir. Professor Harun, would you like to give any comments, sir?
Thank you, Raza. Professor Dharani, Professor Sadaf, welcome, and I would like to welcome the other panelists also on behalf of the Surgical Oncology Society. Gibran, well done, well presented. I'm sorry I joined late, but I think what we are doing is a very important activity, although in a land where we are basically dealing with a lot of advanced, at least loco-regional advanced disease, say due to delayed diagnosis or delayed presentation and everything. Such discussions are very useful. Now, in the setting of this particular trial, which came in during the COVID, I think there are a lot of important lessons to be learned, especially when you're looking at potentially similar pandemic-like situations to come in the times to come. The other thing is that in our setting, if you look at this trial, it's very difficult to monitor our patients on neoadjuvant therapies, chemotherapy, and because in Lahore we get patients from all over, and after getting advice for say short course of chemotherapy or whatever, you really don't know how they are getting it, what they are getting, even the chemo. So I feel that the lesson learned over here is that we should be monitoring and following up very carefully at what our patients are actually getting. So, because so many of the non-responders to neoadjuvant therapy, after some of the patients after full-blown chemotherapy and radiotherapy, even in the traditional type of therapy that is given over here, there seems to be no response at all, and there seems to be upstaging of disease. So I think it's not the tumor biology that is really making the difference. It's how and what. That's the problem. So I think I'll stop here. So this is a long discussion, and give the audience a chance if the participants would like to say something. And regarding when to operate after radiotherapy, I think recently I've had opportunity to operate on patients even at 14 weeks, something like that. And I, for various reasons, and I did not find difficulty in terms of fibrosis or more bleeding. The difficulty was more because of the so-called less response to traditional neoadjuvant chemoradiation and the bulk of the tumor, that sort of a thing. So I feel that you can easily go up to, say, 14 weeks. And in some cancers, say, especially in squamous cell carcinomas, one would like to wait longer rather than go in earlier, because of that statement is based on what Professor Sadaf already told us. Thank you. Thank you very much.
Thank you very much, sir. Dr. Sarich, there is a question directed to you in the chat about what should be the at least clinical stage on MRI for considering to go for RAPIDO trial. I would just going through the trial protocol. I would answer that question just to say that they included T4 tumors with mesorectal fascia involvement, tumors who had extramural venous invasion, and N2 nodes. Leading on to that, I think before I let Dr. Sarich answer that question, I would add one more question to that to include all the other faculty. Do you think having lymph node within the mesorectal facial envelopes, regardless of the number, because N1 and N2 are based on the number of nodes rather than anything else. Regardless of the number, having enlarged lymph nodes within the rectum that can be taken out with a total mesorectal excision, would you consider them as locally advanced rectal cancer requiring neoadjuvant radiation therapy? You can answer this question after answering the question about what stage do you consider on MR to go for neoadjuvant therapy, as has been asked in chat.
So I think the answer, the question has been asked in the context of RAPIDO trial only. So in RAPIDO trial, all the patients who were being included in the experimental arm, they had mandatory MRI, all the patients. And the patients who were stage 2 and stage 3 high-risk patients, as Dr. Raza has mentioned, that 5 risk factors were included in the RAPIDO trial. So yes, stage 2 is stage 3 high risk.
And what about presence of lymph nodes? Do you consider lymph nodes within the mesorectal envelope as an indication for
yes,
neoadjuvant radiation therapy?
Yes, we do.
Dr. Irfan, Dr. Sadaf, your opinions?
So if I, there is and I forget the name of the trials, but now there is data to suggest that if it's all within the mesorectal envelope, then you can take it out. But again, multidisciplinary tumor board is all important. But if I were to think about it, I tend more towards preoperative therapy first. And even though I know that a good surgical resection will take out the involved nodes, my feeling is more about the tumor biology, that these nodes, multiple nodes, indicate to me that this is an aggressive tumor that has breached, basically breached the fortress of the rectum. And, for those people, I like to push for TNT before, because I want to address the micrometastases sooner as compared to later, because I do, I guess over my career, there have been many patients who have not made it to adjuvant therapy on time or have not made it at all. So my preference is that they should get as much treatment as they can upfront. Now, whether I can support that with data is a different question, but that's just sort of my anecdotal preference. Thank you.
Dr. Irfan.
I would agree with Dr. Sadaf and Dr. Sarish on this one. As we are understanding more the tumor biology, and once the lymph nodes are involved, obviously it has become sort of a systemic disease. And with the systemic disease, obviously the neoadjuvant treatment would benefit. Although I know that some of the European centers, if the lymph nodes are within the TME plane and they are away from the mesorectal fascia, so they would definitely take it out first, followed by later with the adjuvant chemotherapy. But yeah, I would be more cautious with that approach as well. I would like our set of patients to go through neoadjuvant treatment first, and early scanning. If there is downstaging, obviously then we can follow them up. We can give them a bit more time to follow up. But if obviously they are non-responders or stable disease, then obviously we can go in early rather than delaying the time period between completion of neoadjuvant treatment and surgery. So
thank you. We also have Dr. Asghar Hussain, clinical oncologist from Cairn Hospital, Karachi. Sir, your comments on this, please. Okay, Dr. Asghar, while he gets his audio corrected, maybe another question related to this. How accurate do we think is MRI in detecting a metastatic lymph node within the mesorectum. Dr. Askar, we'll let you answer your comments on use of preoperative radiation therapy in lymph node positive rectal cancer with the lymph nodes within the mesorectal facial envelope. Could you please unmute, sir?
Is it okay now? Thank you. Sorry, I couldn't attend whole of this session because my opening was on, your it is on. But I have gone through all of this data, and I have gone through the whole of this this RAPIDO trial also. Studies are now moving towards the TNT therapy and do everything before the surgery. Whatsoever the situation, if you're going to radiate first or then completion the chemo, or chemo first and then completion the radiation. When you're going to radiate the patient, wherever is the site of the nodes, whatsoever the sites of involvement of the node, I'm just coming now. So we'll have to, we cover all these things in our radiation field. When it's a part of the rectum, we cover both internal iliac, external iliac. We're going to cover this your obturator nodes also. And even they say, if it's a very low-lying tumor, we can go sometime in covering the inguinal nodes also. Though considering the inguinal node as a stage 4 disease, but we do cover in the radiation field also. So our radiation is going to cover a whole of this nodal region also. So we hope so when you're going to when you radiate all these things and completion of the chemo first as a TNT therapy, pathological response is quite good. That was seen in the case of the RAPIDO trial, which was roughly 28% plus. So I think this is the best treatment now, and we all should now follow all the whole of this treatment regime. Radha, is it okay, Radha? I join you again. Basically, I was busy over here. I just join you again.
Thank you so much, sir. Okay. Question again, the same question. How accurate do we think is MRI in detecting a clinically metastatic lymph node within the mesorectum?
Radha, can I say something?
Yes, sir, please.
If it looks malignant, the lymph node on an MR, consider malignant. And the second thing, if it's say N2 disease, it's likely to be beyond also. So generally our MRs tend to understage. So I mean that's just a you know just a statement and food for thought.
Dr. Irfan, your comments?
I would consider myself very fortunate to be working at Shaukat Khanam. Obviously, we have got radiologists, and obviously we have got paperless systems. So you have worked here as well, so you know better. They can quite confidently pick the involved lymph nodes if they are involved. For a suspicious lymph node, obviously they will say that they are suspicious, but obviously that's not the case all over Pakistan, and that won't be the case outside the good centers. So yeah, I think MR can pick good number of positive lymph nodes, and if they are significantly enlarged and more than like N2 disease, obviously it seems to be a systemic rather than a local disease. That's my thoughts on it.
I agree that if it does look, you know, if it is enlarged and it's clearly visible on MRI, it's probably positive and it should be treated as such. Of course, it's always hard. Then when you give treatment, it's hard to corroborate, right? Because hopefully if your treatment works, you might not find any disease. In fact, you might not find any nodes, which is another problem. The other thing, though, I would put in a plug-in for here is that having, you know, when you come across MRI reports from institutions across, you know, many institutions, we have to have, and I wish our radiology colleagues could look at that, we need to have standardized reporting. Not only is that essential for planning our treatments, but I think it is essential for the person reporting it as well. Very often there are things that are not commented on, which means that, you know, whoever's training with them is not seeing it as well. So I really would make a push for our radiology colleagues. I don't know whether anyone is on here, but I think in our institutions, we should push for standardized reporting for these tumors, just as the pathologists now report according to a standard. I think radiology should do the same. Thank you.
Very much. I think one would have to take the ability of MRI in itself is an amazing modality to look at the involved mesorectal fascia. It defines the planes and helps actually define the surgery. It has not been great in terms of a diagnostic to pick up lymph nodes. And this I'm saying on background of multiple studies by the Mercury, which has been going on over more than a decade. So yeah, the European centers, and that includes some of the centers in the UK as well, that tend to perform surgery or would want to avoid radiation in lymph nodes that appear either increased in size or different in shape, that are within the mesorectal facial envelope. They tend to avoid pre-op radiation therapy based on this premise that MRI is not as accurate in predicting lymph node as it is in terms of predicting the involvement of I think what we have to do is we need to look at extranodal involvement, and that, especially if it is closer to the mesorectum, that is in mesorectal margins. And the other aspect on MRI, which is also part of the RAPIDO trial, is the extramural venous invasion. And we have to really pay attention to it, and we have to actually ask our pathologists to focus on that, because this has actually been shown to predict outcomes. So patients who have extramural venous invasion present, they tend to have a worse systemic outcome in terms of distant metastasis. And actually, patients then receive preoperative chemotherapy or systemic therapy, and their extramural venous invasion actually responds to that therapy, their outcomes are improved, especially in terms of metastasis. This has been shown by the Mercury group. The other more recent development that they have proved by evidence is the presence of or distinction between.
And Dr. Raza mentioned that we do need to have better training and to train our juniors, not only from surgical point of view, but also the radiologist and pathologist to have standardized things rather than suboptimal training or missing things which shouldn't be missed on a proper specimens. Thank you.
Thank you very much. And
Raza, to answer your question, I think the take-home message for this is that we all need to stay tuned. This is a work in progress, and I think we will come across many more studies. And as these studies finalize, and you have your 5- and 10-year outcomes, and as technology changes, as we get new drugs, as we get targeted therapies that become more affordable, the entire treatment strategy is probably going to change. Thank you.
Thank you, Dr. Sadaf. I would like to thank all our faculty. Professor Durrani has commented that he'd be more concerned about mesorectal fascia and the lateral pelvic nodes in MRI. I would request Professor Khalid Durrani to conclude the session with his remarks. Sir, if you could kindly conclude. Thank you very much.
Thank you. It was, of course, a very interesting discussion and pertinent both to surgeons as well as our medical oncologists and radiation oncologists now. If we look at these two trials, then I would like to consider both the RAPIDO as well as the PRODIGE 23 trial. One thing is certain, that these two trials have an impact on a certain group of patients with locally advanced rectal cancer. And I think a period of neoadjuvant chemotherapy, whether in the induction setting or in the consolidation setting, is desirable in patients in which we usually come across in our public sector hospital. They are locally advanced cancers. And if I recall from my past experience, about 15, 20 years ago, when even chemoradiotherapy was not available, sometimes it was a heroic effort to take out the rectum tumor from the rectum without injuring the major blood vessels or even the bladder or various other structures. But certainly with the invent of this neoadjuvant treatment, long course radiotherapy, and now the invent of neoadjuvant chemotherapy, perhaps the task of the surgeons have improved. So to conclude, the total neoadjuvant treatment has certainly made some impact in a certain group of patients. But one can also say at the same time that this is not applicable to all the patients with locally advanced cancer, because we have our own peculiar problems. And in our setup, which is mainly comprising of low and middle income groups, I think if neoadjuvant treatment is to be considered, probably some kind of de-escalation should be considered. Because our patients are always very frail, and they are already exhausted physically, emotionally, as well as financially. And last but not the least, I will also stress on the importance of the total mesorectal excision, because that is one thing which is certainly going to achieve some benefit to the patient. As far as radiation and chemo is concerned, not all patients benefit from radio and chemotherapy, but a perfectly performed total mesorectal excision will save many lives from the misery of local recurrence as well as distant failure. Thank you, Dr. Raza, and thank you, everybody.
Thank you very much, sir. With this, I would like to close. Professor Haroon, would you like to say something before we close as the president of the Society of Surgeons? Oncology Society.
Thank you, Raza, and well done to yourself and everybody else. आज जो लोग तशरीफ लाए उनका बहुत शुक्रिया और आपने काफी टाइम निकाला. I'm especially grateful to our panelists and Professor Khalid Durrani, हमारे उस्ताद हैं, और I think we should continue this in the future. And I think you already made a year's plan for the Journal Club presentations, and we really look forward to them. So I'd like to thank everybody, and Allah Hafiz. Inshallah, mulaqat hogi.
Thank you very much, sir. Once again, thank you very much, Dr. Sadaf, Dr. Sarish, Dr. Irfan, Professor Durrani, and Dr. Asghar, who joined us as well. And the rest of us, we had Dr. Asghar joining from Karachi, as well as Dr. Abdul Wahid, who joined us for a while but was traveling. We would like to conclude this. The next Journal Club will be on the first Saturday of June, 4th of June, and we will be covering hepatobiliary surgery. We will have the flyer out shortly. Till then, Allah Hafiz. Thank you very much, everyone, for joining.
Thank you. Allah Hafiz.
Thank you.
Bye-bye. Allah Hafiz.